My name is Ola. If you don't know me by now, you should. This is my EBM lecture. I'd like to give a shout out to some of the EBM staff, Dr. Benabbas, Dr. Davila, and my mom. Okay, so I don't know if you know this by now, but we work in a hospital in Brooklyn, New York, with the majority of a brown and black population. So in the spirit of hematology oncology, I thought it apt to my EBM conference on sickle cell disease. I was tasked with finding a retrospective study, and I found this little article. It was essentially called a lidocaine and ketamine infusions as adjunctive pain management therapy, a retrospective analysis of clinical outcomes in hospitalized patients admitted for pain related to sickle cell disease. Pretty apt, right? So the aim of the study was to evaluate the efficacy of adjunctive lidocaine and ketamine infusions for opioid reduction and the treatment of sickle cell disease in patients with vaso-occlusive crisis, and to justify the continued study and use on patients with advanced pain syndromes. Methodology. So researchers at the University of Chicago conducted a retrospective cohort study of adults with sickle cell disease admitted for vaso-occlusive crisis from January 2017 to August 2018. All opioid therapy and dose escalations were guided by the primary team, but when that team was not able to effectively manage pain, an acute pain service consultation was initiated. This was roughly done around day 4 of hospitalization, but from days 5 to 10 were also recorded in the study. Infusions were administered at a rate of 0.5 to 2 milligrams per minute for lidocaine and 2 to 3 micrograms per kg per minute for ketamine until pain relief, for a max of 48 hours and a minimum of 24 hours per University of Chicago protocol. Protocols that I have listed on the screen above. Type of infusion and time frame was also up to the physician treating this pain, as this was a retrospective study. Chart review was obtained to get pain scores, confirm diagnoses, and verify oral morphine milligram equivalents. Billing records were also provided for to identify medical utilization, patients' demographics, and general hospital stay. Patients were excluded if they met ICU admission, invasive procedure, or cardiac disease, as opioids may have been used for sedation or post-procedural pain. Additionally, patients were excluded if they received ketamine or lidocaine infusions in the ED or on their first day of admission, as there is no way to establish their inpatient opioid requirements before infusion. Patients were analyzed under 3 groups, either the ketamine alone, lidocaine, or standard of care, which is just opioid use, no infusion. Analysis was conducted on hospital encounters, not individual patients, in an attempt to limit bias and limit placebo effect. The average daily morphine milligram equivalence was obtained up to 3 days prior to the start of infusion therapy and for up to 3 days following the therapy. For encounters with no infusion therapy, i.e. the control group, the therapeutic window start date and duration were randomly assigned as to reflect the data from the patients in the variable groups, as pictured above. Secondary outcomes were to compare length of stay and changes in subjective pain scores before and after treatment window in the groups. Results. So 330 hospital encounters from 68 patients met study criteria. Ketamine and lidocaine infusions were administered to 28 and 29 admissions respectively. However, 27 patient encounters were omitted due to that exclusion criteria, and 4 more were admitted due to receiving both lidocaine and ketamine infusion. This led to a total of 299 patient encounters from 68 unique patients. Overall, compared to the standard of care, ketamine and lidocaine accounted for a respective relative decrease of 28% and 23% in average daily morphine consumption. Patients in these groups were 3 to 4 times more likely to decrease their opioid consumption independent of treatment length or baseline opioid doses. Ketamine and lidocaine therapies, however, were not associated with changes in pain scores. Now for the faculty part.
Hi, good morning. My name is Benabbas. I'm a former resident here and also a current faculty at Kings County. And as part of our EBM lecture today, we are going to talk about retrospective chart review design. As a reminder, the EBM lecture series is mostly about methodology. We want to the goal of these lectures are not necessarily, when we introduce a paper, is not necessarily to change your management, which actually shouldn't. It is more about the methodology of that paper and how to identify biases, identify what methodology is best, what methodology has biases, all of that. So today we're going to talk about retrospective chart review study. So retrospective studies, as it comes from the name, is when you start from the outcome, you already have all the outcomes, and then you look backwards to look at what interventions the patients got or what risk factors they had, you look back in time. So that's what retrospective studies are. What are the benefits of retrospective chart review studies? Why do people opt for doing these kind of studies? The biggest reason is time. Doing prospective studies looking forward is very time consuming, especially if you're looking at a disease that is rare or you need large sample size. You might need to look at data for years and years and spend a lot of time in order to get to results. So as a way of cutting time, looking backwards, you already have that data for, let's say, 3 years, 5 years, 10 years, and looking at that database cut the time that takes to actually do the research. The other reason is this related is funding. So anybody who has ever been part of an RCT knows that they are very expensive. You need research coordinators, you need statisticians, you need multiple levels of checking on the data, which is good and which is the reason these studies are our gold standards. But you need a lot of money to do it, and getting grants for studies is sometimes a barrier, and retrospective studies are a lot cheaper to do. The other reason and one of the use of these studies is when you're looking at rare diseases. So if you're looking at a very rare, like say, genetic disease, you might need to wait 10 years in order to get 50 patients, right? If the disease is really rare, but if you're looking back, then you don't have to wait that time. You can look back at the database. So and also for rare diseases, it's really hard to find funding to do proper RCTs, unfortunately. So these are the reasons people do retrospective studies. What are the disadvantages? The biggest one is that you are dealing with data, charts, patient charts, and not actual patients. So you're at the mercy of whoever documented the chart. And we all know the charting can be very variable between different people, and even for the same person on different shifts. It depends on how sick your patient is, how busy your department is, what mood you're in. Are you documenting in real time, or at the end of your shift, you're trying to just put something in the chart, which you shouldn't, but we all do. And I don't know about you, but when I am seeing hypertension, chest pain, shortness of breath, whatever I'm seeing in the emergency room that day, I'm not necessarily thinking about, oh, what if somebody needs my chart 5 years from now for research, right? We document for patient care, we document so that the next person knows what we did. And we sometimes document, we also document to legally protect ourselves if something goes wrong or if somebody is looking at our chart. But most of us, I would say, are not documenting for research purposes, right? And we all know from experience, and we all know from data that's out there, that when you're looking back at these charts, there's going to be very variable quality of charting, and there's going to be a lot of missing data depending on who in real time documented that patient encounter. So you can have, for the same patient, a chart that is like an assessment plan like this, very brief, or you can have something longer, or you can have a medicine resident documenting a very long, very detailed note, right? These are essentially the same patient. An older patient came in with abdominal pain, had some lower left lower quadrant tenderness. Both providers are thinking this might be diverticulitis. Their plan is the same. But if somebody looking back at this chart and trying to extract data for research, then how are you going to deal with the fact that patient 1 and patient 2 have very different data points in their chart available? How are you going to deal with this missing data that chart number 1 has, right? So this is one of the caveat is that there are certain data that you can almost be sure that every chart has and pretty consistently. Let's say arrival vital signs. Anybody coming to the emergency room is going through triage and they're getting vital signs again. So you're pretty much can be sure that if you're looking at like arrival vital signs, that is something that's going to be the same almost in all of your charts. Or NIH scores. I mean, there's different in how people like interpret that, but there is going to be an NIH score in the chart of every stroke code patient, right? But when you go beyond that and in the details, especially about history and physical exam, there's going to be a lot of variables and a lot of missing data. The other problem is that even if your database is good, even if your charts are good, especially if you're going in without a specific question in mind, different people can look at different data, same data set and come up with different conclusions, because it all depends on how many charts you're looking at, how many years you're going back, what is your question, how are you looking at it? And kind of the worst way of doing this, which is why I put this on, is people who are like, oh, I have this database, I have this like number of charts, let's dig through it, see what we can find. And a lot of times, if you're approaching it that way, you might come up with conclusions that are statistically significant, but not necessarily clinically correct or significant. It's kind of like the elephant in the dark room, Rumi story. Depending on which parts of this data you're looking at, you're going to come with like different conclusion. And this is true even for good databases. So this is a very robust database on ESRD patients in the United States. The database is actually really good, and it is available freely to researchers for analysis. But there is actual papers published on this that different researchers looking at this same database have published kind of conflicting or different conclusions, even about things like mortality, even about things like peritoneal versus like hemodialysis, even about kind of very specific questions, because it all depends on how you look at it, which part of it you look at. The other issue, as you probably know, is biases. The retrospective chart review studies have a lot of biases. Now, I'm not going to go over all the biases because hopefully at some point we'll have a lecture just going through different biases. But some of the important ones is recall bias. Recall bias refers to when one group recalls events better than the other group. This is a big problem in pediatric studies. If you are asking a mom of a teenager who has asthma or learning disability or any issue, and you are asking them, okay, when they were 3 years old, what kind of exposures they had, they are more likely to remember because they have spent a lot of time probably thinking about that, as opposed to someone that has a child that doesn't have those diseases. Then you have your observer bias, which happens when researchers' opinions, prejudices, expectations kind of influence how they perceive or record in the study. And then you have the ascertainment bias, which is data that is collected, has a kind of it can include some parts of like the members of the population more than others. Example of this is that you're looking at breast cancer and you come to a conclusion that patients with higher socioeconomics have more breast cancer, but they actually don't have more breast cancers because they have more access to screening, right? And then the other one is response and non-response bias. When people who are willing or unwilling to, these are especially for people that you're calling back saying, hey, 5 years ago when you were in the emergency room, or this disease that you have 5 years ago, what kind of exposures you had? There's a difference between people who respond to that and don't. And then the other thing is confounding factors. It's really hard to control for confounding factors when you're looking at retrospective studies. Kind of because we are kind of limited on time, I'm gonna skip this. It's a whole lecture in itself. But are retrospective studies completely useless? No, they are useful in terms of, there are some situations where you can't do prospective studies, you can't do RCTs, and like it might be unethical to expose a group of patients to, let's say, carcinogens. But retrospectively, this is a landmark study from 1950s in England, where they looked at patients with lung cancer and looked at their smoking history, and kind of this is the reason we think like a smoking leads to like lung cancer. So they have some use. They're especially good for kind of looking at trends and creating research ideas of, okay, this seems to be the trend when I'm looking at the chart. Now let me do and actually properly study this prospectively. So they're not useless. So now what do we do? You have a chart review study coming up. You're already excited about it. Should you just abandon this study? No. But you have to know how to properly do it. So I'm going to kind of quickly go through how can we make our retrospective chart review studies better. So instead of just having a database and go look at it and see what you can find, you need to have a protocol, a very specific research question, even before you look at any data. What am I looking for? What is my specific research question? Then you have to have a protocol that hopefully you have already written and already decided on which charts am I looking at? What time frame? How am I looking at this? What are my inclusion criteria, exclusion criteria? How am I dealing with missing data? What statistical analysis I'm going to use? So all of these needs to be predetermined in a protocol before you go and start your study. And you should get IRB approval because you're dealing with patient data, unless you are using like a database, like that ESRD database that I was talking about. If you're looking at the charts of patients in your institution, you should get IRB approval. And then this part is the part most studies miss, and we're gonna go and look at the data for that, is who is actually looking through these charts. So usually what happens is that a group gets together and like, okay, we're gonna look at these many charts from like the past 5 years. Who is actually gonna go extract the data? Oh, we have this medical student who is really interested in research. You go look at the data and put it in an Excel sheet. Not to say that a medical student can't do that, but that is actually your most important part of your study, the person actually looking through the data and getting you the data. So you want to make sure the person, the data abstractor, the person who is going through the charts has some sort of training. You want to make sure they have some sort of form that you're going through, like these are the things you're looking for. These are the things, these are the orders you're going. If you can blind the person to the kind of what the study is about, that would be great. And then you want to have some, if you can have like 2 reviewers looking at every single chart, that is ideal, but that's usually not possible. You want to at least have some chart that somebody else is also looking at, and looking at like inter-rater reliability, the 2 people that looked at the same chart, how much did they come with the same data, right? And then those are basically the main things. So how well are we doing this? This study is now like I think there was one of these studies in 1996, and this is kind of like updated one in 2005. I didn't see much after that they looked at. This one is looking at 79 retrospective chart review studies published in 6 main EM journals, like the ones that we all know, Annals of Emergency Medicine, AEM, all of those, the 6 main ones. And they looked to see how much they actually adhered to these kind of criteria that we talked about. So as you can see, even though we have improved from the 1990s, there is still only like, let's say the blinding of the person looking through the chart to the hypothesis, it's only like 5% adherence. So you're still not there. It seems like things are improving, but let's say inter-rater reliability is a domain that we have really improved on. In like 1990s, the only 0.4% of these chart review studies actually look at inter-rater reliability. Things are getting better, so it's not hopeless. But these are kind of the things you want to look at. I don't think I have more time, so I'm going to kind of wrap it up. Any questions, comments before?
Okay. Building off Dr. Benabbas's lecture, we're going to now look at the strengths and weaknesses of this study presented. So this is now the resident quality assessment. All right. So some of the ideal practices for retrospective studies that were previously mentioned, again, were those perspective elements, data collection and analysis, and ethical considerations and quality control. Starting off with perspective elements for my study, I do believe they hit most of these aspects on the head. identify the study question beforehand. I believe they did do that. Can adjunctive therapy reduce opioid use in sickle cell disease? It was stated, and that's what they were trying to ascertain. As for the second point, I also believe that they did describe their inclusion and exclusion criteria beforehand. Lastly, I believe they succeeded in defining the study variables as well, analyzing for age, sex, treatment, window length, baseline opioid dose, day of stay, and whether any NSAIDs, membrane stabilizers, methadone, or Tylenol was used before. In terms of data collection and analysis, this is where they lost some hypothetical cookie points for. For the first point, developing a study protocol, I believe this was not appropriately done. The choice of infusion, intervention, and time was left up to the discretion of the treating physician. This was either done by the primary team or acute pain consultant, as this was up to the discretion of whichever doctor was treating the patient and no formal protocol was established. It left room for bias at this stage. For the next point, utilizing a standard data collection form, I think they also fell short of this as well. There was no real listed protocol or manual for data collection, and it seems like it was up to the discretion of the ones coming through the data. So the poor medical student, maybe. For no real, in terms of point three, there was also no mention for the training for investigators who extracted the data. And lastly, there was no inter-rater reliability assessment or blinding for the people who extracted the data. All these shortcomings lead to less credibility and validity for a non-randomized control intervention. In terms of ethical considerations and quality control, they successfully completed one of the first steps to most credible studies, getting IRB approval. They also passed point two, consistently applying study policies, hence the drop of recorded hospital encounters due to patients meeting exclusion criteria. There, however, was no documented plan for missing data. So all in all, to recap some of the strengths in the study, they got IRB approval, they defined the study question beforehand, accurately defined their inclusion and exclusion criteria, and also defined possible study variables. For weaknesses, however, there was no set protocol for interventions. There was no set protocol for data extraction. They didn't list any formal training for investigators extracting the data, and there's no inter-rater reliability assessment or blinding. We know that randomized control trials are the gold standard for research. It is very important for these non-randomized control interventions to try to adhere to these policies to decrease bias as much as possible. I just wanted to mention the Robbins Eye tool. This is a risk of bias in non-randomized studies of interventions. This is another tool that people can use to evaluate bias in non-randomized control interventions using the domains that I showed listed on the screen. In terms of final thoughts, overall, I still thought this was a very interesting study, especially when compared to our patient population. Sickle cell disease affects 100,000 Americans and is almost in 1 in every 365 African Americans. It has a high mortality rate that's been decreasing since we've been treating it, but it can still pose as a challenge for emergency medicine physicians to treat acute pain. At first glance, you might just read this paper and think, oh, great, let's give ketamine to everyone. But when you start reading the nitty-gritty details of studies like this, you start finding that that may not be the case. I say all this to not say that there can be nothing garnered for this for this study. The perspective elements were great, but it lost a lot of those points on those analysis and data collection, which is what a lot of retrospective studies do lose points on. But one of the objectives of this study was to justify the continued study of patients that are being treated for complex pain syndromes. And I believe they at least shown that more studies and research is warranted into doing just that. We're excited.